Okay, today's topic in the UNCRAFT Adult Safeguarding Week is, as you know, organisational abuse, which we've kind of looked at in terms of safeguarding, I guess, and what safeguarding means and how it interrelates to organisational abuse. And I suppose the flip side of that, if you like, is that without organisational safeguarding, there's more chance, or there's a greater likelihood, in effect, of organisational abuse. So that's the kind of approach we're taking. And I'm delighted to say that we're joined today with Sarah Owen, by Sarah Owen, and Sarah has worked with us for a number of years now, and kind of lent her safeguarding expertise to, amongst other things, safeguarding adult reviews, SAR inquiries, but also has this kind of medical stroke clinical background and comes from the safeguarding nurse perspective. So, Sarah, I wonder if you wouldn't mind telling us, if you can sum it up, what your current role is, because I know you work with the CCG at the moment, and what your previous role was when you worked, and when we first met, when you worked for MFT, Manchester Foundation Trust.
Oh, thanks, Jed. Thank you for giving me the opportunity to be part of this conversation. So my current role is that I am the designated nurse for safeguarding adults at Trafford CCG, which I've currently been in the position for 12 months. The role is to be able to ensure that the safeguarding systems are in place with the providers that we commission, and that we've got appropriate monitoring and assurance processes to deliver and make change of where we can see that there are gaps or movement within safeguarding. My previous role was, as you've mentioned, working in an acute trust as a name nurse for adult safeguarding, which I worked for a number of years.
Sarah, let me just interrupt you for a second there. So just tell us what an acute trust is, Sarah, because people might not know what that is.
Yeah, absolutely. So an acute trust is generally what people would attend for their medical appointments at a big hospital, generally. There's quite a few in Greater Manchester, namely Manchester Foundation Trust, Salford Foundation Trust, there's Tameside, Wigan, etc. So it's the hospitals.
So when you work for the hospitals, your role was slightly different. So at the moment you work for the CCG, and for people that don't know, that is the Clinical Commissioning Group, which is a branch of the NHS that basically commissions acute services, which is hospital services, and primary services for the borough of Trafford. That's what you're doing at the moment.
Yeah? That's what I currently do. Yeah, absolutely.
And prior to that, you worked for Manchester Foundation Trust on the acute side. I'm really sorry I interrupted you there. So just tell us a bit about what you did when you were on the MFT side of things.
Yeah, so pretty much all acute trusts, they have a safeguarding, in-house safeguarding team. And I think there's a general confusion around safeguarding, because there's teams within each area. So there's a safeguarding team within a trust like Manchester Foundation Trust. It's a very large team. It consists of over 60 members of staff, just because of the size of the organisation. And the role of that team is to be able to respond and react to safeguarding referrals that are sent in internally and externally. So, for example, staff would have concerns about a patient's presentation when they arrived in the emergency department, whether that's to do with domestic abuse, their presentation of noticing of injuries. Maybe they've come from a home setting or a care home setting, and their responsibilities to be able to make a referral to the safeguarding team in the local authority. So there's that clear distinction between the safeguarding team in the local authority and the safeguarding team in an acute trust. And it's a feeding system, isn't it, of being able to provide and use good communication methods and sharing of intelligence to safeguard the individual. That's the process.
Okay, so I kind of struck by for the listeners, maybe just explain that my background is in the police. I was a detective inspector in the public protection investigation units, and those units are about trying to investigate crime and to safeguard people but in relation to individuals that are highly vulnerable. So basically, it looks at on the one hand children, and I know we're not here to talk about children today, but on the other hand, it looks at vulnerable adults as well. So they might be adults that are subject to domestic abuse, but equally there might be adults that are abused because they've got learning difficulties, or elderly folk that are subject to financial abuse, whatever. So the point is, I think that the golden thread running through that, from my perspective, is the vulnerability in relation to adults. But I suppose when we've been talking about how we might discuss this topic, I think what you're talking about in terms of your role is about developing and building processes that safeguard folk when they come into hospital, and recognising when they might be vulnerable, at risk as they come through the doors, and recognising when they might be vulnerable and at risk during the stay, and then, without repeating myself, afterwards upon discharge. So a lot of your work is around, I think, and please do correct me if I'm wrong, is about kind of developing processes and ensuring people comply with those processes, the professionals comply with those processes, and then when things go wrong, as inevitably within large organisations they will, working out why they're going wrong and kind of inquiring into that. Does that summarise that? And can you, before I start swinging the lamp and talking about the good old bad old days of what I understand organisational abuse to be, do you want to just talk us through a little bit more about the nature of that work?
I think so. I think that it's a very broad area, and I think you've covered some of the absolute topics of processes and structures and the appropriate governance within large organisations to ensure that safeguarding is everybody's business, and that we're very clear and open and transparent about that. I think that the amount of work that is generated through the safeguarding processes and acute trusts is a continued challenge, and generally that comes through the incident reporting system that is recognised in an acute trust, and there may be a number of those incidents that are reported that have oversight by the safeguarding team to be able to understand themes and trends of where our safeguarding concerns lie, and in particular within organisational abuse. So I think some of the key areas that spring to mind are areas in relation to falls, individuals that fall whilst in the care of an acute trust in an acute hospital, or falls that have occurred outside of the hospital. Pressure ulcers is another key fact, and maybe medication errors that have occurred that actually lead to that person suffering some further harm whilst in the care of an organisation that should be there to promote and maintain safety. I think it's important to recognise that the population of patients within the NHS has changed dramatically over a period of time. We're all fully aware of the resource and struggles that acute trusts have with the capacity of patients that attend and the complexities of the NHS and its current format. And I think that's really why my role from moving from an acute trust into the CCG is where my idea of being able to make more systemic changes within the system, rather than managing the day-to-day safeguardings on a case management point of view, which the safeguarding teams in hospitals do, really well. And as you've explained, that ability to have that relationship within the safeguarding partnership between providers, the police, the local authority, and being able to share that information only strengthens our ability to be able to provide assurances that safeguarding, organisational safeguarding, is apparent, and that there are still themes and trends that appear that would meet the thresholds for organisational abuse, but that there is work in the background and intelligence from all the teams working in areas such as safeguarding, trying to mitigate those risks.
So, I mean, from what you just said there, Sarah, it sounds to me that you've gone from kind of a case-driven workload largely to now a much more strategic overview type role, where I guess without overstating it, what you're doing is you're bringing your experience to bear from the acute setting where you dealt with innumerable numbers of cases, which is where professionally you and I know each other from, because we often dealt with safeguarding adult reviews, and I would call upon you to explain to the board, to the partnership, what had happened in this particular case. But you've moved from that to a much more strategic role where, frankly, you know what the expectations are now, and I guess you will feed those expectations into things like commissioning arrangements, oversight and assurance from the CCG's point of view, to the acute setting, to the hospital. Is that more or less it?
Yeah, I think that's exactly it, Jed. I think that my want to be able to use the experience that I'd gained with the teams in acute trusts to be able to make changes to broader aspects of safeguarding. So for working within the CCG, and my role as a designated nurse for safeguarding gives me the ability to report into the regional safeguarding team, which reports into the national safeguarding team. So I'm just that step closer of being able to be the voice of these acute trust safeguarding teams, of the challenges that they face and the themes that are emerging, to be able to escalate those appropriately and be able to support national change, because we do know, don't we, that the Care Act in 2014 and adult safeguarding has been a long time coming, hasn't it, to be able to have that same voice as the children's safeguarding team, to be able to protect the vulnerable adults that you've described so well.
Yeah, and I think I think we feel very passionately about the kind of what we at times as professionals feel that there is a bit of a lag phase here, and we are somewhat behind the curve. I don't know whether that's because of the kind of high-profile stuff that was coming out in the 2010s, or just because the legislation actually in relation to children's safeguarding and children's abuse is that much older and that much more established. But I think things like the Safeguarding Week, this kind of means, if you like, of bringing it into the public's consciousness are really, really important. And it just, I suppose, just kind of allows us to talk about it and to I think just explain what safeguarding is, because people don't really understand it. I think everybody understands inherently or intrinsically what child abuse is. And I don't want to talk about child abuse, but it's less clear, I think, what adult safeguarding and adult abuse or elder abuse is. Maybe I can use the next couple of minutes just to talk about, and we can perhaps reflect together, but just talk about my experiences of organisational abuse, and because as I started to say earlier, I was a senior investigating officer within Greater Manchester Police, and I spent probably the last 10 years operationally principally investigating cases of organisational abuse, and they excuse me, they either related to, in the case of adults, to care homes and so on, or they might, in the case of children, relate to schools. But I think the way that I understand organisational abuse is very different to the way that you understand it, because I understand organisational abuse as how somebody gets away with abusing people within an organisation when really they, apart from it being unlawful and immoral and all of those other things, apart from that, they have no right to do that, because if the organisation is set up correctly and is sufficiently transparent and is sufficiently inquisitorial about what it does and how it does it, and asks the right questions and puts people under the right spotlights when those questions are asked, that organisational abuse should never happen. It should never happen. But, as is the way of things, I guess it does happen, and it has happened in the past. And much of the work that I did was around historical abuse, and I think it is important to state that. And I think when you have people in positions of trust and positions of power, that other individuals within that organisation are reluctant or afraid, or simply just can't countenance the fact that they might be abusing people, then that becomes a hotbed for the success of abuse. And I know that's not what you're talking about in terms of your role in safeguarding, but I guess it's really to compare and contrast that was my role in safeguarding, which was to kind of, I guess in a way, investigate and root out those individuals and bring them to justice. And I suppose to draw those two scenarios together, I would say that what the end result of all of that work was, and often is, the learning that comes about from kind of saying, how did this happen? It's not so much, the guilty going to prison, which is part of the process, obviously, but it's kind of saying, how did that happen? What were the weaknesses in the system that enabled this individual to offend for 20 years and for nobody to feel as though they were empowered to speak up? And in a way, I think your role, and I think the role of people like you, is the product of all of that inquiry, insofar as actually it's about making things really transparent. It's about bringing it it's making it important enough to have people in roles that do things about safeguarding and putting, being a bit clumsy here, but I think what I want to end on is you put the processes in place that stop the offenders offending. And that's where the world of the police officer and the world of the DESI, as we call it, designated safeguarding officer, or nurses that work in safeguarding, come together. Because the product of the police officer's work is the requirement for processes that protect people, whether it's from falls, whether it's from dodgy prescribing, whether it's from pressure ulcers, or indeed whether it's having systems in place that are sufficiently transparent that can point the finger at somebody and say, actually, that is not quite right, that behaviour is not quite right, because there are rogue individuals that operate within acute settings, and they have made the headlines over the years, haven't they? So I guess what I'm trying to say is that's how you draw it together in terms of your experience and my experience. I don't know whether you have any comments on that, Sarah.
I think you're right, Jed. I think that we've come a long way in adult safeguarding, and we've still got some way to go. It's a journey, isn't it, that we're on together. And I think the partnership is key. And I think when you talk about some of the work that you did historically within your role as operationally within the police, and we look back to some of some days previous to that, time previous to that, a lot of organisations worked in silo, didn't they? I.e. the police, local authority and health. And I think the safeguarding partnership of being these core partners together, police, local authority and health, CCG, means that we've got that greater opportunity to safeguard individuals. I agree. I think have got experiences of individuals that have been alleged as being perpetrators of patients whilst in the care of a hospital setting. But in my experience, these are rare, as we would hope, due to some of the processes that are in place, such as safer recruitment via DBS, policies and procedures, training, the ability to feel that staff can speak out, and whistleblowing policies. As you mentioned, the person's in positions of trust, work that's been done since the involvement of the Care Act being enforced. I think all these changes make a difference, don't they? And that ability to be able to investigate cases and learn lessons. And I think we both agree that some of the frustrations with some of the lessons that we learn within organisational abuse, and this will be something that's nationally recognised, is that the themes and trends are there, aren't they? We've got the themes and trends, but they're multifactorial and complex, and they need lots of layering of different work streams and commissioning and workforce and resources to be able to provide the ever-changing nature of care for very complex individuals.
Yeah, I couldn't agree more. And thank you for mentioning partnership there, because you know, I really believe, and this is going back. I'm now talking to somebody that you know, started off a career in the police 35, 40 years ago, and there was a really distinct role. Well, that's police work because that's enforcement, and that's social work. And you let the social workers do the social work, and we'll do the policing. You know, thank goodness that has changed now. And inherent within you mentioning, I think, partnership is the fact that actually, you know, safeguarding is everybody's business, and I know that it's a phrase that gets trotted out, but actually it is everybody's business, because safeguarding people is about a partnership, a multi-agency approach to all aspects of people's lives, whether it, you know, and it might be enforcement, but it certainly will be social care and support, and it will be health, and it will be, you know, things as disparate as housing and education, and all those other things that keep people safe. So, you know, thanks for mentioning partnership. It's so important, and the robustness or otherwise of partnership arrangements that professionally, you know, we work together and we hone over the years, and we do hold each other accountable, makes that a success, or if it's not there, makes it a failure.
I think you're right, Jed. I think the safeguarding board partnership, bring the one that we have locally within Trafford, has good relationships with all those key partners, don't they? I recognise that as a partner, that I feel that we've got people to be able to lean on and seek advice and support and gain that experience from other areas. And I think that Trafford Safeguarding Partnership goes some way to be able to make that as accessible as possible. And that's helpful. Thank you.
Yeah, no, well, thanks for those comments. That's what we're aiming for, and hopefully, you know, always room for improvement, but hopefully we're heading in the right direction. Right, what I'd like to say is thanks very much for giving us the time and the opportunity just to talk to you today. It's been really, really helpful. I think not only, you know, I'm used to working in these situations and working with yourself and other safeguarding health professionals, but I think the usefulness of this, if you like, is that it explains to people outside of our sphere exactly how you operate and how you work, which I think is really important. So I'm very grateful for that, and we'll put it on the website if you have no objections.
Thank you,
Sarah.
Thanks, Chad.